Hello everyone. Today we have talk about respiratory system diseases and finish it this part of our topics. Um, Lung diseases are some of the most common medical conditions in the world. Hundreds of millions of people have lung diseases in the world. Smoking, infections, and genes cause most lung diseases. The lungs are part of the complex system, expanding and relaxing thousands of them each day to bring in oxygen and send out carbon dioxide. Lung diseases can happen when there are problems in any part of the system. Today we will learn the main syndromes of the respiratory system. They are respiratory failure, the syndrome of the pulmonary infiltration, creation of cavity and lung tissue, the syndrome of accumulation of fluid and air in pleural cavity, the syndrome of atelectasis and lung expectation. The major basic diseases of the respiratory system such as bronchitis, COPD, group pneumonia, bronchopneumonia, bronchial asthma, lung abscesses, pleural effusion, pneumothorax, symptomatology independent work with patient creation of medical history. But before we begin the diseases, I'd like you to talk about what is a symptom, what is a syndrome, and what is a diseases. Symptom is a departure from normal functions of feeling which is apparent to a patient, reflecting in the presence of an unusual state of a disease. A symptom can be subjective or objective. Tiredness is a subjective symptom, whereas cough or fever are objective syndromes. What is a syndrome? The syndrome is a set of medical signs and symptoms that are correlated with each other and often with a particular diseases or disorders. The word derives from the Greek, what means concurrence. So the syndrome is a complex of syndromes. So the syndromes are as a collective of collection of symptoms. And what is a disease? A disease is a particular abnormal condition that negatively affects the structure or functions of part of all an organism, and that is not due to an external injury. Diseases are often constructed as medical conditions that are associated with specific symptoms and signs. You know that there are many lung diseases. Of course, we cannot talk and learn in one lecture all of the diseases, and it's very difficult to remember that. So I'd like to divide these lung diseases by part. What are dependent on the material and what they are. You know that there are many respiratory system diseases, and in one lecture it is impossible to learn and study everything. So for remember easily, we will divide it into some parts and learn in such way. Let's begin with lung diseases which affecting by airways abnormalities. You know that windpipe or trachea branches into tubes called bronchi, which in turn became smaller tubes throughout your lungs. Diseases that can affect these airways include asthma. These airways are constantly inflamed and may spasm, causing wheezing and shortness of breath. Allergies, infection, or pollution can trigger asthma symptoms. Chronic obstructive pulmonary diseases, COPD. With these lung conditions, you can exhale the way usually would, which cause trouble breathing. Chronic bronchitis. This form of COPD brings a long-term with cough emphysema. Lung damage allows air to be trapped into your lungs in this form of COPD. Trouble blowing air out is its hallmark. Acute bronchitis, the sudden infection of airways, is usually caused by a virus. There is also cystic fibrosis, which these conditions have trouble clearing mucus out of bronchi. This leads to a repeated lung infection. Another part of lung disease are diseases that are affecting the ear sacs, or how we are calling them alveoli. This is there is another part of the lung diseases what are affecting by the ear sacs, or by alveoli, how we are naming it. Airways branch into thin tubes, bronchioles, that end in clusters of ear sacs called alveoli. These ear sacs make up most of lung tissues. Lung diseases affecting alveoli include, first of all, pneumonia. It's an infection of alveoli, usually by bacteria or viruses, included the coronavirus that causes COVID-19. Tuberculosis, pneumonia that slowly gets worse, caused by the bacteria Mycobacterium tuberculosis. Emphysema. This happens when the fragile links between alveoli are damaged. Smoking is the usual cause. Emphysema also limits airflow, affecting the airways. Then pulmonary edema. Fluid leaks out the small blood vessels of lungs into the ear sacs and the area around them. One form is caused by heart failure and back pressure on lungs blood vessels. In another form, injury to lungs cause the leak of fluid. Another form is lung cancer. It has many forms and may start in any part of lungs. It most often happens in the main part of lungs, in or near the ear sacs. The very important diseases are acute respiratory distress syndromes, ARDS. This is a severe sudden injury to the lungs from a serious illness. For example, COVID-19 is one example. Many people who have ARDS need help breathing from a machine called a ventilator until their lungs recover. Pneumoconiosis. This is a category of condition caused by inhaling something that injury the lungs. Examples include black lungs diseases from coal dust and asbestosis from asbestosis dust. Let's speak now about lung diseases affecting by the interstitium. The interstitium is a thin, delicate lining between alveoli. Tiny blood vessels run through the interstitium and let gas transfer between the alveoli and the blood. Various lung diseases affect the interstitium. This is first interstitial lung disease, ILD. This is a growth of lung conditioning that includes sarcoidosis, idiopathic pulmonary fibrosis, and autoimmune diseases. Pneumonia and pulmonary edema can also affect the interstitium. Lung disease is affected by blood vessels. The right side of heart gets low oxygen flow blood from the veins. It pumps blood into lungs through the pulmonary arteries. Lung diseases affected by blood vessels. The right side of heart gets low oxygen blood from veins. It pumps blood into lungs through the pulmonary arteries. The blood vessels can have diseases as well. Pulmonary embolism, a blood clot usually in a deep leg vein called deep vein thrombosis, breaks off, travels our heart and gets pumped into lungs. The clots stick in a pulmonary artery, often causing shortness of breath and low blood oxygen levels. Pulmonary hypertension. Many conditions can cause high blood pressure on pulmonary arteries. This can lead to a shortness of breath and chest pain. Lung diseases affecting by the pleura. The pleura is a thin lining that surrounds our lung in the lines, the inside of our chest wall. A tiny layer of fluid lets the pleura on our lung surface slide along the chest wall with each breath. Lung diseases of the pleura include, at first, this is pleural effusion. Fluid collects in the space between our lungs and the chest wall. Pneumonia or heart failure usually causes this large pleural effusion, can make it hard to breathe and may need to be drained. Pneumothorax. Air may get into the space between our chest wall and the lung, collapsing the lung. Mesothelioma. This is a rare form of cancer that forms on the pleura. Mesothelioma tends to happen several decades after our come into contact with asbestosis. And at last, lung disease may be connected with chest wall. Our chest wall also plays an important role in breathing. Muscles can connect our ribs to each other, helping our chest expand. Our diaphragm descends with each breath, also causing the chest expansion. Diseases that affect our chest wall include obesity, hypoventilation syndrome. Extra weight on our chest and belly can make it hard for our chest to expand. This may cause serious breathing problems. Another diseases are connected with neuromuscular disorders. We might have trouble breathing when the nerves that control our respiratory muscles don't work the way they should. These diseases continue: amyotrophic lateral sclerosis and myasthenia gravis. They are examples of the neuromuscular lung diseases. Let's now begin to learn specific diseases of the respiratory system. And first of all are the respiratory failure. This is the inability of the cardiac and pulmonary systems to maintain an adequate exchange of oxygen and carbon dioxide in the lungs. These diseases we have met very frequently is the major cause of the death, not only in China, but all over the world. More than 70% of patients with pneumonia are attributed to the respiratory failure. For this respiratory failure has the specific syndrome such as dyspnea and cyanosis. You know, we have met these syndromes when we learned percussion, inspection, and other physical methods of respiratory system. So the dyspnea is the early symptoms of respiratory failure, and in these times we have increased breath rate. As you know, cyanosis are peripheral and central. Peripheral cyanosis is associated with stasis in which oxyhemoglobin is reduced more than it normally because of the prolonged peripheral blood transit time, while the pressure of oxygen could be normal. And central cyanosis result from arterial hypoxemia. The respiratory failure divided into two parts, as everything. The acute respiratory failure and chronic respiratory failure. We can say we have acute respiratory failure if we have the pressure of oxygen less than 50 millimeter of hydrogen, it's named hypoxemia, and carboxyl dioxide pressure are more than 50 millimeter hydrogen. This is named hypercapnia. There are changed also pH acid base indices. It became less than 7.35. The chronic respiratory failure defined as deterioration in gastric chains that has occurred over a long period of time after an episode of acute respiratory failure. Absence of acute symptoms and presence of chronic respiratory acidosis, patients develop tolerance to a gradual worsening hypoxemia and hypercapnia, COPD, and neuromuscular diseases. The main cause of the respiratory failure are COPD, pneumonia, asthma, atelectasis, and pulmonary embolism. Now, let's talk about such pulmonary diseases such as cavitary lung lesions. What is a cavity in the lung? You know, inside the thorax are sponge-like dishes. What is entire and have no cavity in other cyst? A cavity is a gas-filled space seen as a lucency or low attenuation area within a pulmonary consolidation. A mass or a nodule has a lucent area within the lung that may or may not contain a fluid level and that is surrounded by a wall, usually of varied thickness. Cyst also is like a cavity. Cysts in the lungs are defined as any round, circumscribed space that is surrounded by an epithelial or fibrous wall of variable thickness, usually thin walled, test less than 4 millimeter. So you can see X-ray of cyst and cavity, and how we differentiate it. We differentiate only by the distance of the wall. In the cyst is less, it's very thin, less than 4 millimeter, and in the cavity, the wall are more than 4 millimeters. There is useful mnemonic cavity for main cause of the cavitary diseases. Where the C means cancer, this is bronchoangioplasty, mostly frequency cavitary pulmonary metastasis. A means autoimmune granulomatous form, such as Wegener's granulomatosis. B, it means vascular. I is means infection, T is means trauma, and Y is means use. Maybe when we have some pulmonary sequestration and bronchogenic size. Pleural effusion. This is very spread diseases, and you will meet it in every in your physician work. So you must learn it very carefully. Pleural effusion is a collection of fluid in the pleural space. It's really a primary disease process, but is usually secondary to other diseases. Usually, the pleural space contains normally 10 to 20 millimeters of serous fluid, and it is normal. When we have abnormality, we have transudative effusion and exudative effusion. Transudative effusion may be from pathophysiology. This is also known as hydrothoracis, occur primarily in non-inflammatory condition, and it is accumulation of low protein, low cell count fluid. The cause of transient effusions are increase of hydrostatic pressure found in heart failure, most common cause of pleural effusion. Decrease oncotic pressure from hypoalbuminemia, found in cirrhosis of liver or renal diseases. In this condition, fluid movement is facilitate out of the capillaries into the pleural space. Exudative effusion. This occurs in an area of inflammation, is an accumulation of high protein fluid. So the difference between exudative and transudative is a protein, whether it is high protein or low protein fluids. Exudative effusion results from increased capillary permeable characteristic of inflammatory reaction. These types of effusion occurs secondary to conditions such as pulmonary malignancies, pulmonary infections, and pulmonary embolism. Etiology is disseminated cancer, pleural pulmonary infections such as pneumonia, heart failure. So it is not only from respiratory system, but maybe from the heart diseases such as heart failure, maybe from cirrhosis and nephrotic syndromes. Other conditions may be sarcoidosis, systemic lupus erythematosus, and peritoneal dialysis. What we have clinically in these cases? Usually the clinical manifestations are those caused by the underlying diseases and severity of effusion. Pneumonia causes fever, chills, and pleuritic chest pain. Malignant effusion may result in dyspnea and coughing. When a small to moderate pleural effusion is present, dyspnea may be absent or only minimal. There is pleuritic chest pain, dullness of flatness to percussion, and decreased or absent breath sounds. For you, very important to take and pay attention about physical notes of these diseases. From here, you must remember that in case of hydrothorax, we have dullness and the decrease of absent breath by auscultation. Diagnostic evaluation, the main diagnostic method is chest X-ray and ultrasound detects presence of fluid. Thoracic synthesis, biochemical, bacteriological, and cytological studies of pleural fluid indicates cause. You can see here on the X-ray that we have here left pulmonary hydrothorax is here. If you remember, we learned it in the percussion and we mentioned Damoiseau line. This will be Damoiseau line, whether it divides the abnormal part of the lung to the normal part of the lung. And it's important here, you must learn it in 100%. What physical notes we have in case of pleural effusion. By percussion, as we say, we have dull, flat over the fluid. The trachea shift towards the opposite side in a large effusion. You know why, yes. Breath sounds are decreased to absent, but bronchial breath sounds may be heard near top of the large effusion. This is this moment when the bronchial sounds are abnormal. You know that normally bronchial sounds are on the first two intercostal space over the where the bronchs are divided. There so we have sometimes when we have reconvalescence of from pleural effusion, maybe we have pleural rub. You know, yes, what's the sound of pleural rub? Like two people are doing the sawing of wood. By investigation of tactile fremitus, we have decreased to absent, but maybe increased towards the top of large effusion. We know there is consolidation and we have decreased fremitus. Now, another disease is pneumothorax. Pneumothorax is a presence of air in the pleural space. It may be three types: spontaneous, result of iatrogenic injury, and trauma to the lung of chest wall. Spontaneous or primary, in case of this diseases, we have no evidence of over lung diseases. Occurs in male aged 15-30. Air escapes from the lung into the pleural space through rupture of a small emphysematous bulla or pleural bleb. Smoking told stage the presence of apical subpleural blebs are additional risk factor. Secondary underlying lung diseases occurs mainly in male above 55 years, most commonly after COPD or tuberculosis, associated asthma, lung abscesses, pus in parts, pulmonary infarcts, bronchogenic carcinoma, all forms of fibrotic cystic lung diseases. Second is traumatic pneumothorax. It may be iatrogenic. What it means that the injury may be from therapy or from physicians, and chest wall injury when they occur the violation of the integrity of the wall. We have next types of pneumothorax. This is closed spontaneous pneumothorax, open spontaneous pneumothorax, and tension pneumothorax. I say directly that the most danger form is tension pneumothorax. Closed types. Communication between airway and the pleural space seals off as the lung depletes. Mean pleural pressure remains negative. Spontaneous reabsorption of air, re-expansion of lung occur over a few days or week. Infection is uncommon in these cases. Open types. Communication between pleura bronchus does not censor bronchopleural fistula. Intrapleural pressure equal to atmosphere pressure. Collapsed lung, no re-expansion. Expansion. Transmission of infection from the airway into the pleural space through fistula is common. It causes emphysema. And tension type, what it means. Communication between the airway, the pleural space acts as a one-way valve, allowing air to enter the pleural space during inspiration, but not escape on expiration. Large amount of air accumulates progressively in the pleural space. Intrapleural pressure increases above atmosphere pressure. Pressure causes mediastinal shift towards the opposite side, with compression of the opposite lung. Impairment of systemic venous return, causing cardiovascular compromise. You can see here that the mediastinal shift are changed to the counterwise side here. There is became compression of opposite lung here. Occasionally, tension pneumothorax may occur without mediastinal shifts. If malignant diagnosis or scarring has splinted the mediastinum. Occasionally, tension pneumothorax may occur without mediastinal shift. General examination, what it gets us. At first, we see cyanosis, rapid thready pulse, sign of peripheral circulatory failure in severe cases. By inspection and palpation, we have dyspnea, accessory muscle or respiration, shift of trachea, shift of mediastinum on opposite side, fullness of chest on the affected side, diminished chest movement. Marked diminished vocal fremitus in affected side, reduction in total chest expansion, increase in size of affected hemithorax, diminished expansion of the affected hemithorax. By percussion, we have hyperresonant on affected pneumothorax. Right-sided pneumothorax lever dullness is obliterated and cardiac dullness is shifted to the opposite side, because the heart and the wall are now the ear. What get us hyper resonance sound. By auscultation, we have diminished or absent breath sounds, absence of adventitious sounds, diminished local resonance, bronchopleural, fistula, amporic, bronchial breathing. Here you can see what may be in case of pneumothorax. There must be dyspnea, anxiety, tachycardia, pleural pain, asymmetric chest wall expansion, and diminution of breath sound. On the right side is the causes of the pneumothorax. Ruptured blepia, thoracocentesis, trauma, secondary infection, and so on. So it's important. Excuse me. You must again say you must remember in 100% what are happening in case of pneumothorax. Trachea are shifted towards opposite side. By percussion, we have tympanic or hyperresonance sound. Breath sound are decreased or absent over the pleural area. We have non-adventitious signs, or maybe we have possible pleural rap in case of reconvalescence, and primitus, vocal primitus are decreased to the absent over the pleural area. Now about atelectasis. What is atelectasis? Atelectasis is defined as the collapse of closure of the lung resulting in reduced or absent gas exchange. It may affect part or all of one lung. Atelectasis is the collapse of alveoli of lung tissue. It develops when the alveoli become airless from absorption of the air without replacement of the air with breathing. You can see here the normal alveoli and the collapsed alveoli in case of atelectasis. Etiology is the obstruction of an airway and diminished distension of alveoli. We have next clinical manifestation: cough, sputum production, and low-grade fever, marked respiratory distress, dyspnea, tachycardia, tachypnea, pleural pain, and central cyanosis, difficulty breathing is supine position, and anxiousness. By instrumental examination, we have in chest X-ray, patch infiltrating or consolidation areas. By pulse oximetry, we have less than 90% of oxygen. By physical examination, we have decreased breath sounds and crackles are heard over the affected area. You have the how the lungs are diminished and shrinking in the thorax. And physical notes by percussion. We have dull or over airless area. Trachea may be shifted towards the involved side. You can now see the differences between pneumothorax and atelectasis. In case of pneumothorax, the trachea are shifted opposite the involved side, but in case of atelectasis, the trachea are shifted towards the involved side. Breath sounds usually absent when bronchial plaque persists. Exceptions include right upper lobe atelectasis, where adjacent tracheal sound may be transmitted. We have no adventitious sound in here, and by primitus we have usually absent the bronchial plaque persists. In exceptions, it has right upper lobe atelectasis may be increased. Now, about pneumonia. Everybody may be even not a physician now what is a pneumonia. Pneumonia is a breathing respiratory condition in which there is an infection of the lung. Pneumonia is a leading infection, cause of death in children worldwide accounting for 15% of all deaths by the children under 5 years old. Pneumonia caused by bacteria can be treated with antibiotics, but only 1/3 of the children with pneumonia receive the antibiotics they need. The lungs are made up of small sacs called alveoli, which fills with air when a healthy person breathes. When an individual has pneumonia, the alveoli are filled with pus and fluid, which makes breathing painful and limit oxygen intake. You can see here, this is normal alveoli and is pneumonia. There may be liquid here or maybe pus and maybe their blood also. Causes of pneumonia. You know, we have bacterial causes and viruses causes. From bacteria, the most spread Streptococcus pneumonia, and by viruses, Haemophilus influenza type B. And so there is pneumocystis jirovecii in infant infected with which. There is the symptoms of the in case of pneumonia. You know well this causes. There is symptoms: shaking, chills, fever, dry cough, muscle aches, nausea, vomiting, rapid breathing, rapid heartbeat, difficulty breathing, and chest pain. Classification of pneumonia. Maybe someone you know. We have lobar pneumonia. This occurs due to acute bacterial infection of part of lobe or complete lobe, commonly Streptococcus pneumoniae, Staphylococcus, and so on. Bronchopneumonia, acute bacterial infection of the terminal bronchioles characterized by purulent exudates, extend into surrounding alveoli through endobronchial route, resulting into patchy consolidation. Common streptococci, Staphylococcus aureus, Haemophilus influenza, and so on. Intestinal pneumonia. Patchy inflammatory changes, mostly confined to the intestinal tissues of the lung, without alveolar exudates. You know what means interstitial. This is texture what are situated and placed between the alveoli, mostly confined to the intestinal tissue of the lung without alveolar exudates, characterized by alveolar septal edema and mononuclear infiltrates. Commonly Mycoplasma pneumonia, respiratory syncytial viruses, influenza virus, adenoviruses, and so on. Now about pathological stages of pneumonia, lobar pneumonia. We know that the pneumonia has 4 stages. Let me see and talk each of all each stages. The first stage is a stage of congestion, represents early acute inflammatory response. Affected lobe became red and heavy due to vascular congestion. Proteinaceous fluid, abundant neutrophils, and many bacteria can be seen in the alveoli. The duration of the stage is 1 to 2 days. Then, second is stage of red hepatization. Affected lobe becomes red, firm, and acquired liver-like consistency. Proteinous fluid transforms into fibrin strands with marked cellular exudates of neutrophils. Extravasation of red cells, which give red color to the consolidation lung. The duration of the second stage path of red hepatization is 1 to 4 days. The third stage are stage of gray hepatization. Affected lobe becomes dry, firm, and gray due to lysid red cells. Neutrophil cellular exudates decreases due to the breakdown of inflammatory cells, and macrophages are now seen. Microorganism load also reduces. The duration of the stage are 4 to 7 days, and it lasts the stage of resolution. Due to enzymatic action, fibrinous matter is liquefied, and the lung aeration is re-established gradually. Macrophages are the major cell in the alveoli. These are progressive reduction of fluid and cellular exudates from the alveoli by way of expectoration and lymphatic drainage, leading to a normal lung parenchyma in over 3 weeks. You can see here the scheme of these 4 stages. I remember you that it begins with congenital stage, then go to red hepatization. Here are many erythrocytes here. Then red erythrocyte became the gray, and we have gray hepatization. And the 4th stage are stage of resolution. Now about lobar pneumonia. The etiology is approximately the same as others. The clinical features are also similar. There we have shaking, chills, fever, malaise with pleuritic chest pain, dyspnea, cough with expectoration. The common physical things are fever, tachycardia, and sometimes cyanosis if the patient is severely hypoxemic. Bronchopneumonia. Etiology are the same. Clinical features, there is chronic debility, aspiration of gastric contents of upper respiration infection, neutrophilic leukocytes. Now about interstitial pneumonia. The etiology are respiratory syncytial viruses, mycoplasma pneumonia. Mycoplasma is a mushroom like pneumonia. Influenza and parainfluenza viruses, occasionally psittacosis, chlamydia, and Q fever, coxiella are also associated. Clinical features of the interstitial pneumonia is fever, headache, and muscle aches. A few days later appears dry, a hacking, non-productive cough with retrosternal burning, neutrophilic leukocytosis. And at last, our life physical notes. Of course, they are changed in stages of the pneumonia, but we must general note of this physical notes. This is dull over the area, sound by percussion, trachea is midline, no shifted, not inside, not outside. There is bronchial over the involved area from adventitious sounds. Late inspiratory crackles over the involved area, and by tactile tremitus, we have increased over the involved area with bronchophony, hypophony, and whispered pectoralici. Now, about chronic obstructive pulmonary diseases. COPD is also known as chronic obstructive lung diseases, chronic obstructive airways diseases, quad, chronic airflow limitation, CAL, and chronic obstructive respiratory diseases, square D. Chronic obstructive pulmonary diseases refers to chronic bronchitis and emphysema, a pair of 2 commonly coexisting diseases of the lung in which the airways became narrowed. This leads to a limitation of the flow of air to and from the lungs, causing shortness of breath. In COPD, less air flows in and out of the airways because of one or more of the following. The airways and air sacs lose their elastic quality. The walls between many of the air sacs are destroyed. The walls of the airways became thick and inflamed, and the airways make more mucus than usual, which tend to clog them. You can see here how the walls are damaged here on alveoli here. In these cases, this is normal wall and this damaged wall. Causes of COPD. And the first place is smoking, then occupational exposure. Exposure to workplace dust found in coal mining, gold mining, and the cotton textile industry, and chemicals such as cadmium, isocyanidin, and fumes from welding have been implicated in the development of the airflow obstruction. It's a common cause is air pollution, as in sudden airway constriction in response to the inhaled irritants, and bronchial hyperresponsiveness is a characteristic of asthma. COPD includes in his bronchitis emphysema. Bronchitis, the condition in which the bronchial tubes became inflamed, acute and chronic. They are acute and chronic infections or lung irritants cause acute bronchitis. Chronic bronchitis is an ongoing serious condition. It occurs if the lining of the bronchial tubes is constantly irritated and inflamed, causing a long-term cough with mucus. You can see here location of the lung and the bronchial tubes. There you can see the bronchial tube with increased secret mucus here. And this mucus are very big obstacle for breathing. What signs and symptoms has COPD? Is a sore throat, fatigue, fever, body aches, stuffy or runny nose, vomiting and diarrhea, persistent cough. Cough may produce clear mucus, shortness of breath, wheezing and chest discomfort. The coughing may produce large amount of mucus. This type of cough often is called as smoker's cough. There we have scheme of chronic obstructive pulmonary diseases symptoms. There is weight loss, wheezing, chronic dyspnea, cough and sputum, chest tightness. In the chronic bronchitis, we have inflammation of bronchioles, excess mucus, and muscle constriction. You can see how the bronchos are narrowed here. And also we have the membrane degraded here, who is also obstacle for oxygen and breathing. Now about emphysema. Emphysema is a lung condition that causes shortness of breath. In people with emphysema, the air sacs in the lungs are damaged. Over time, the inner walls of the air sacs weaken and rupture, creating larger air spaces instead of many small ones. You can hear how the alveoli are damaged in case of emphysema. So are the widening the sacs. Physical signs. We have learned that in case of emphysema, we have barrel-shaped chest. Accessory respiratory muscle are participating in breathing. There is prolonged expiration during quiet breathing, expiration through pursed lips, paradoxical retraction of the lower interspace during inspiration, and tripod position. You have seen the barrel-like chest that the distance of transspinal anterior-posterior distance are the same. At this tripod position, when muscles are helped to breathe this patient. And it's also important what we have physical notes. Palpation have decreased prematus vocals, in percussion, hyperresonant, depressed diaphragm, diminution of the area of absolute cardiac dullness. By auscultation, we have prolonged expiration, reduced breath sounds, the presence of breathing during the quiet breathing, crackle can be heard of infection exists. Now about bronchitis. We talked about bronchitis, and it was during the COPD. And now let me talk about individual bronchitis. Now about bronchitis. We know that bronchitis is inflammation of a swelling of the bronchial tubes. So we have acute bronchitis and chronic bronchitis. Etiology, in first place, are smokers, people who are exposed to a lot of secondhand smoke, people with weakened immune systems, the elderly and infants, people with gastroesophageal reflux, GERD, people who are exposed to air pollution. What signs we have here? Inflammation or swelling of the bronchi, coughing, shortness of breath, wheezing, fatigue, fever, and chills, chest pain or discomfort, blockage of runny nose. And the most interesting thing is um, physical notes. By inspection, we have cough with thick sputum, chronic bronchitis produces dyspnea, fatigue, possible clubbing of fingers. By palpation, we have tactile phlebitis is normal. By percussion, we have resonant, so normal sound. By auscultation, we have normal vesicular voice, prolonged, but the differentiated sign of the bronchitis is prolonged expiration may be present with chronic bronchitis, may have wheeze or crackles over the defected areas. Diagnosis and evaluation. We have historic collection, physical examination, chest X-rays, sputum cultures, pulmonary function test, spirometer exercise, and bronchoscopy. For that, we treatment of the bronchitis, we use medicaments such as antibiotics, cough medicine, and bronchodilators. Mucolitis, these are seen on loosened mucus in the airways, making it easier to cough up sputum. Anti-inflammatory medicines and pulmonary rehabilitation programs. This includes work with a respiratory therapist to help breathing. In case of bronchitis, we have next complications such as asthma, bronchoectasis, tuberculosis, and sinusitis. Now is a very famous disease is bronchial asthma. Asthma is a chronic inflammatory disease of the airways which develops under the allergens influence associated with bronchial hyperresponsiveness and reversible obstruction and manifest with attacks of dyspnea, breathlessness, cough, wheezing, chest tightness, and sibilant rals more expressed at breathing. Asthma is a chronic inflammatory disease of the airways which develop under the allergens influence, associated with bronchial hyperresponsiveness and reversible obstruction and manifest with attack of the dyspnea, breathlessness, cough, wheezing, chest tightness, and the sibilant rals more expressed at breathing out. According to epidemiological studies, asthma affects 1 to 18% of population of different countries. Causes. The main cause is allergic reaction, so plants foreign bodies in the airway. Etiologies, allergens are divided into communal, industrial, occupational, natural, and pharmacological. Communal allergens are contained in the air of apartment houses. They are house dust mixed with live-in carpets, mattresses, and upholsters, vital products such as domestic insects, tobacco smoke during active or passive smokers, various communal aerosols, and synthetic detergents. Among the industrial allergies, there is very nitric, carbonic, sulfuric oxide, formaldehyde, ozone, and emissions of biotechnological industry. There are some allergens which may cause asthma. There is house dust, dust of book, pharmacological agents, plant pollen, spite excrements of the domestic animals, and even the food. some stabilizer genetically modified products. The asthma triggers are cigarette smoking, pollen inhalation, dust, changes of the weather, exercise, even exercise, cockroach, food allergens, cold weather, furry pets, and strong smells. Trigger factors which provoke bronchosmas are a simultaneous penetration of a large quantity of allergen, viral respiration, infection, hyperventilation, physical exertion, emotional stress, becoming too cold, adverse weather condition, administration of some medicines, maybe even aspirin and beta blockers. But pathophysiology asthma is quite difficult and insufficiently studied. Undoubtedly, in most cases, this is based on first hypersensitive reaction. The genesis of any allergic reaction may be divided into immune, pathochemical, and pathophysiological phases. We can characterize asthma by spasmodic, such as sporadic in nature with varying intervals of free and difficulty due to precipitating factors of readily defined and continuous. Some shortness of breath on occasion, transit wheezing on strenuous exercise, and wheezing heart deep inspiration. Intractable, persistent wheezing require regular daily medication for either control of symptoms or ability to function. And the most severe form of status asthmaticus, attaching which patient deteriorate in spite of adequate treatment. You can see the normal bronchioles and bronchioles in case of asthmatic. You can see how the neuroid, the opening are here. Out clinical manifestation of the asthma. There is attack of expiratory dyspnea, shortness of breath, cough, chest tightness, wheezing, beautiful sibilant rals. A typical case development of asthma contains exacerbation, and we have three periods here: prodromal period, the high period, and the period of reverse changes. In the prodromal period, there is vasomotoric nasal reaction with profuse watery discharge, sneezing, dryness in nasopharynx, paroxysmal cough with viscous sputum, emotional lability, excessive sweating, skin itch, and other symptoms may occur. The peak of exacerbation, they are respiratory dyspnea, forced position with supporting on arms, poorly productive cough, cyanotic skin and mucous tunics, hyperexpansion of thorax with use of accessory muscle during breathing. And what is the main for us? At lung percussion, we have tympanitis, shifted downwards lung borders. At auscultation, we have diminished breath sounds, sibilant rals, prolonged breathing out, tachycardia. In severe exacerbation, the sign of right-sided heart failure, swollen neck, veins, hepatomegalia, overload of right heart chambers on ECG. In the period of the reverse, we have which comes spontaneously or under pharmacological therapy. We have dyspnea and breathless relief or disappear. Sputum becomes not so vicious. Cough turns to be productive. Patient breathing, yeah. So everybody is calming in case of reverse changes. And what happened in case of asthmatic status. This is severe and prolonged asthma exacerbation with intensive progressive respiratory failure. There is hypoxemia, hypercapnia, respiratory acidosis, increased blood viscosity, and the most important sign of blockade of bronchial beta-2 receptors. The asthmatic status has his stages. First stage is refractory response to beta-2 agonist, relaxation of the smooth muscle. Second stage are silent lung because of the severe bronchial obstruction and collapse of small and intermediate bronchi. Third stage, the hypercapnia coma. In many cases, asthma, particularly intermittent, manifests with few and atypical signs, such as episode of appearance of wheezing, cough, heavy breathing occurring at night, Cough, hoarseness after physical activity, seasonal cough, wheezing, chest tightness, the same symptoms occurring during contact with allergic irritants, a lingering course of acute respiration infection. We are made diagnosis mainly by clinical manifestation. Management, we avoiding the contact with allergen, elimination of trigger factors, rational job placement, changing the residence, and optimally selected medical care in the base of asthma management. We inhale it, combine it, drugs by nebulizer, tube inhalers that enhance the effectiveness of the asthma therapy. We take oxygen. We give the patient systematic corticosteroids, maybe hydrocortisone, give the patient inhalation of short-acting beta-2 agonists such as salbutamol, gave inhaled anticholinergic drugs like aminopilin, and if there is no effective, we are go to the artificial lung ventilation. Prognosis. In case of early detection and adequate treatment, the prognosis for the disease is favorable. It became serious in severe, persistent, and poorly controlled intensivity for corticosteroids asthma. The patient with unfavorable for the disease condition often needs a job replacement. Physical laborers with severe asthma are disabled to work. For prophylaxis, it's the basis of primary asthma prophylaxis. The prophylaxis is preservation of the environment, healthy lifestyle, smoking cessation, physical training. The preservation of the environment, healthy lifestyle are the basis of the primary asthma prophylaxis. These measures in combination with adequate drug therapy are effective for second prophylaxis. And our physical note in case of asthma. By percussion, we have hypersonant resonant, two diffusely hyperresonant, trachea not shifting anywhere. This is in the middle position. Breath sounds often obscured by wheezes. There is only wheezes and possible crackles, and tactile parameters are decreased because there is much air on the lungs. Now, lung abscesses. What it means, there is a pus on the lungs. What is lung abscesses? They are localized the area of destruction of lung parenchyma, in which infection by biogenic organisms result in tissue necrosis and suppuration. It manifests radiographically as a cavity within a fluid level. The lung abscess may be primary or secondary. Primary are when the abscess in previously healthy patients or in patient at risk for aspiration. In secondary is associated with bronchogenic neoplasm or immunocompromised patient. The etiology are aspiration or oropharyngeal pleura, dental periodontal sepsis, paranasal sinus infection, depressive conscious level, and so on. Etiology, hematogenous spread from a distal site, abdominal sepsis, pelvic sepsis, infective endocarditis, intravenous drug abuse, infected intravenous canal, and septic thrombophlebitis. What is the mechanism of the infection? Its common cause is aspiration of oropharyngeal contents. 75% of the abscess occur in posterior segment of the right upper lobe or apical segment of either lower lobe. This being the segment to which aspirated material has been shown to gravitate in the supine subject. What symptoms we have? There is common symptoms here: fever, cough and sputum production, night sweats, weight loss, anemia, hemoptysis, pleurisy. There are no signs specific for lung abscesses. There is digital clubbing, dullness of percussion, diminished breeze, sound if abscess is too large and situated near the surface of lung. And there is a new characteristic of basic amporic, cavernous breeze sound, when we have the big cavern in the lungs. We're doing diagnosis by CXL, CT of the chest. Difficult to isolate anaerobic bacteria. General if symptoms and the clinical setting right for anaerobic infection, generally treat empirically. We use gram stain both positive and negative also, or mix it. We use bronchoscopy with quantitative cultures and further none of this specimen likely to yield anaerobic after antibiotic therapy initiated. We must do differential diagnosis for caveated lung cancer, localized emphysema, infected bulla, infected congenital, pulmonary hematoma, and etc. In case of these diseases, we really need surgery, but sometimes we need to do it. Indication for it, the failure of medical management, suspected neoplasm or hemorrhage. Predictors of poor response to antibiotic therapy alone is abscesses associated with an obstructed bronchus, large abscesses more than 6 centimeters in diameter, relatively resistant organisms such as P. aeruginosa. The usual procedure in such case is a lobectomy or pneumonectomy, even pneumonectomy. And complication. This is emphysema, bronchopleural fistula, pneumothorax, hemotoxis, metastatic cerebral abscess, sepsis, fibrosis, bronchiectasis, amyloidosis. So this is all the respiratory system diseases. Of course, there are many of them, but you will learn in as upgraded classes for you. Thank you. Good luck, and I wish you very success to mid-range examination.